when we talk about sensory, we're going to talk about a couple different disorders. I'm going to start off with Duchenne's muscular dystrophy, multiple sclerosis, Parkinson's disease, and seizures. So we got a special guest with us. It's my brother Alex, and the reason he's here is because he has Duchenne's muscular dystrophy. Okay, so I figured why not teach y'all through actual person, instead of just showing you PowerPoint slides and stuff like that. Let's actually have someone here talk about that. So, what is Duchenne's muscular dystrophy? It's an X-linked recessive disorder. There's a mutation within the dystrophin protein on the genetic code. With this protein of dystrophin, it is actually allowing for that muscular structural integrity. So when your muscles deteriorate or you work out, you have these small little tears, little fiber tears within your musculature, and dystrophin actually comes in and repairs that muscle. Okay, so anybody with Duchenne's muscular dystrophy doesn't have that dystrophin protein that allows for that muscle repair. So what does it mean for us when we have an X-linked recessive disorder? Anybody have any ideas, thoughts?
That's a DNA disorder.
I'm sorry?
It's like a DNA change disorder, like on your chromosome.
It will. Good. So let's go back to our Punnett squares. So females have what type of chromosomes?
XY.
XX, right?
Oh, my bad.
Yep. It's okay.
Look, quit looking at me like.
Males have what?
XY.
XY, good. Okay. So it's X-linked recessive. So we have a small little, we'll put a little R right there, and that's your Duchenne gene right there, okay? So we run our Punnett square out. Ooh, my handwriting is awful. Okay. So this population right here is what we're most affected by, okay? So with Duchenne's muscular dystrophy, it's mostly going to affect white males. You will see a few females that are affected by this as well. But the reason that it's affected is because we have a defective X chromosome with this, but do we have another X chromosome to cancel out that defective part?
No.
No, we just have another Y, okay? So that's why the majority is gonna be males. So for instance, with this one, we have one X that is affected, but we have another X that can cancel out that effect. And so that's when we're gonna have our carrier right there. Right, so this mother, this female, is gonna be a carrier that she can then give off to her offspring. So whether it be a male or female. This one's not affected, and then this is where I live within our family gene. So, of course, I'm the firstborn, so technically I'm supposed to have it as well. But then Alex came along, and here we are. Huh? Does that make sense to everybody?
Is it just a, is it a recessive gene?
Yes. It's put on the genetic code that does dystrophin. I want to say it's gene 72, don't quote me on that, but within that genetic code is where it's going to live. Okay. So what?
Something they can supplement?
They were working towards a cure for it. It's not curable currently, but the cure is to either skip over that defective dystrophin gene itself, and so then at a point it would just stop the disease process wherever it currently is. Nothing would ever backtrack, or there's going to be, they're looking on a few new drugs as well, that's actually going to supplement the dystrophin protein itself. Still not going to backtrack the disease progression, but just stop it where it is. So they've had some good success with some clinical trials here recently, but it's very specific to which Duchenne disorder or muscular dystrophy it's going to be. Okay. All right, so what are they going to look like? What are they going to present as? When they first start, really you're not going to notice any symptoms until around 4 or 5 years of age. Okay. So when Alex was going through kindergarten. I'm gonna talk to you in third person. Anyways, so when Alex was roughly pre-K, that pre-learning stage right there at kindergarten age, that's when we really started noticing those symptoms. Okay? And we really started noticing fatigue, frequent falls, so we would go to like Walmart or Dollar General or something like that. And he couldn't even walk to the back of the store before he got tired. So he wanted to either get in the buggy or wanted someone to carry him, lift him up, something like that. And then every now and then he would even fall. And then also we would start to notice when he started playing with other kids, he wasn't able to go as strong, as fast, typically as some of the other kids. They would have to rest a little more frequently with that. And then we had an actual physical therapist was coming through his pre-K program, and she started to notice some even more distinct signs. So the two main signs and symptoms that you're going to see with Duchenne is going to be the Gower sign, and then they have the Duchenne walk or waddle, as they call it. Okay. So what do I mean by Gower's sign? So with the Gower sign, they're sitting on the floor, they're crisscross applesauce, whatever you want to say, and as they're trying to get up off the floor, they're losing that weak strength in their legs, so they're kind of weak in their legs. And so they'll kind of get on all fours, stick their butt way high up in the air, okay? And then they'll start to use their arms, walking up their legs to a standing position, okay? So they're trying to compensate for that loss of muscle tone, that loss of strength within their lower extremities, their lower half, okay? Actually, notice gets off on all fours, he's sticking that butt way out, not as much, some of them do more than others, and he kind of gets to that standing position. Walking up with his arms. So that's one of your classic signs. So either might possibly have Duchenne's. I also get up off the floor like that too, because I'm just fat and old. So that's whatever you want to take it as. The other one is the Duchenne walk or waddle. Okay, so I need a volunteer for this one. All right, Amber, come on.
Trust no wife, show us how.
I'm always down to do something. Hey, back off.
You've had kids, right?
Three of them.
So you remember when you were super pregnant, fixing to give birth, your back was aching and you had to. Yep, remember that?
Yep.
Okay. All right, do that. All right, bring your shoulders all the way back. Okay, good. Stand on your tiptoes. Now walk. Okay. And then you got your arms going too.
Oh, I'm holding the pregnancy.
Stand nice and tall on your.
Oh my word, I'm looking forward to that.
Right, so it's real funny, and it looks kind of odd. It's very uncomfortable to keep sit down, unless you want to keep going back and forth. No.
Is that gonna be your new walk when you're not falling asleep at clinical? Is that your new walk?
Yeah, that's gonna be my new walk and you're gonna see it.
So it looks real weird, real awkward, but there is a purpose to this. Okay, so as they're losing that muscle mass, that muscle tone within their lower extremities, they're trying to compensate. All right, so their core muscles, their hip muscles, the gluteus maximus, your glute muscles right there in the back. Okay, that's where they're trying to distribute their weight, and trying to gain some of that extra strength, allowing them to walk a little bit further. And so that's how they compensate for it. Also, when they're starting to lose that muscle tone within their lower extremities, their Achilles tendon starts to tighten up as well. And so that's how you're getting more of that pointed toe effect, and while you're kind of walking on your two toes. Okay, so they're trying to maintain that balance, trying to get that strength into their core, into their hips, allowing them to walk a little bit further. Okay. So this is a progressive disorder as well. So with these signs and symptoms, it goes a little bit further down, gets more serious, more intense, and go down the list. With Duchenne's, it's gonna affect your voluntary muscles first, right? So again, the lower extremities will start to affect your upper extremities as well. Some of that fine motor movement skills, things like that, okay? And then eventually we'll start affecting your involuntary muscles as well. So cardiac wise, respiratory wise, and eventually it'll start affecting the mouth as well, the tongue, things like that, okay? So like I said, it affects cardiac muscle as well. So if we look at our EKG here, we can see some of that damage that has occurred over time. So of course we have our P wave right here, the little first hump, that's your atrium contracting, remember, giving off that electrical impulse. We have that QRS complex, so right through here, that's kind of that big mountain that we see. Remember, that's your ventricle spiring, okay? And then we'll have a little bit of a T wave right through here as well. And that's when your ventricles are going to start to relax. If we look at our ST segment, so your Q, R, and S, and this T wave right here, so your ST segment, that's showing that cardiac damage. So see how it's kind of dipping down from that baseline, that middle line right there? You see it kind of throughout here as well. It kind of has that U shape right there. That's old cardiac damage right there, okay? So you might also hear ST elevation or STEMI and MI, and that's going to be new onset acute damage. That's people for heart attack. So once they recover, once they get some treatment, then they'll start to see some of this ST depression, kind of this U shape, goes kind of under the baseline right here, and that's kind of show that old cardiac death. Okay. So, how do we treat Duchenne's muscular dystrophy? Really, it's symptomatic management at this point. Like I was telling Chuck, there's no set cure right now. There's a lot of clinical trials that are going on right now for very specific certain mutations of the genetic code for Duchenne's. So it's very selective on what they're using to treat it. So it's all symptomatic management. So we look at Alex over here. When we're talking about symptomatic management, we really have to talk about I ain't never been a while, guys. Barely. We're going around. Good. I'm impressed with this. Okay, that's close enough. All right. We're going to talk about the quality of life. All right. So, if you talk about respiratory status wise, that's what this is going to be right here. Okay. So there's a lot of different options. We can have BiPAP, CPAPs at night for the obstructive sleep apnea that they might occur. Okay. They can even go all the way up to tracheostomy. Okay, and have continuous supportive ventilator care if they want to. Okay, but if the patient doesn't want it and they just want a good quality of life, then they can choose not to, and that's totally up to them. Okay, but this system right here is kind of like a BiPAP system right here. We call it a hookah because it looks like a hookah. That's not the real term for it. You're not smoking or anything. It's actually called a sip and puff is what it's called. Okay, so it's very similar to a BiPAP. It has a big machine right here on the back, and every time he puts a good firm seal around this little straw right here, it blows a big old puff of air into his lungs. So it's allowing him to get that big, adequate deep breath that he needs, allowing for that oxygenation, that CO2 gas exchange to occur. And just allowing a good deep breath of air, okay? So it's more like a CPAP because it's just allowing air in, not necessarily allowing air out, okay? And cardiac-wise, so he was started on beta blockers a long time ago, back when he was first diagnosed, all right? So it's lowering that heart rate, lowering that overall stress of that heart, trying to maintain that heart function as long as possible. So he actually came back from a cardiologist today, and his EF was like 43, 44, so which is really great for him. So with people with this disorder. So we'll see people with their EFs in the 10s, 20s. Okay, very nice CHF, just heart failure. Okay. GI wise, what are they at risk for? So it starts to slowly affect the tongue, esophagus, so he's not able to swallow, as well, has some dysphagia going on. So what's he have this for?
Bowel obstruction.
Bowel obstruction, good, so you had one of those, a while back too, right, Alex? Yep, something like that. That was a big ordeal, he flew in a helicopter and did the whole thing, he went out in style, that was pretty cool. So yeah, bowel obstruction, what else? Is he able to eat anything? Right now, okay, what if we put something in his mouth?
Choke.
Choke, okay, what else? What can he get besides?
Aspiration.
Aspiration, good. So is there risk for aspiration pneumonia?
Yeah.
So what can we do instead?
Tube.
Feeding tube, good. We won't show you that on camera. Good. So since this is a childhood illness or childhood disease, they will have a feeding tube. If they'll have something put in that's a little more long-term, we won't see the traditional classic peg tube that we normally see. So I'm sure a lot of y'all have seen a peg tube in clinical at this point. It has this nice long dangling thing right here. But these kids are up moving around, they're playing until they're in a wheelchair. So that can get snagged, you get hooked on different things. What if they're rolling around in the bed? They're with this very long term. So what Alex has is a Mickey button, is what they call it. And it's just a small little tube right here. Looks just like a little button, and it's placed within the stomach. Okay? So it acts just like a peg tube. Alright? But instead of using a syringe, we also have to have an extension set as well. So it's hard to see on here, you might be able to see it on your power plant itself, but there's a little piece right here, a little connector piece, that'll go actually right here in this hole. It kind of locks in into place, and allowing you to infuse, you can do it continuously, where you can do bolus feedings, where he gets 5 or 6 a day. You get 3 or 4 a day, he does. He's a vegan these days. They change up the 2 feeding formulas. So they'll change up their 2 feeding formulas based on their nutritional status. So if they need a little bit more calories, they can change how much protein is within that little 2 feeding little shake bottle. If they need more vitamins, electrolytes, things like that, they can change it up based on his overall weight. And he's actually getting kind of fat, so that's good. That's what we want. So, yes.
Back to the Mickey button, I had a student that had one of those at the elementary clinical center.
Awesome.
And I thought it was really interesting, the little extension part that they had.
Yep.
For parents, for like based off of insurance, the little connector part, I think it kind of sucks because you only get like one of those like once every 2 months, I guess based off like each individual insurance.
Well, how much you get?
You get 1 a month.
1 month, okay.
They're $20 fees, you buy them out of pocket.
Oh, okay, that's what I asked that. I thought it was 2 months, but the next.
Still, he's using that 4 or 5 times a day,
Yeah,
every day for a month.
yeah.
It's gonna get pretty nasty pretty fast. They also have a little,
With vinegar and water
Yeah.
every day after every use, but the formula is really sticky and you can't get it clean.
Yeah.
So soak it underneath it in the hot water. And it gets really gross by the end of the month, so we usually just buy extra, so we don't have to. Plus it gets moldy in the hot weather, it's in the car, but anyway.
But it does connect up really easily. I thought it was interesting doing it at the elementary clinic that we had.
I love it.
Yeah,
I love the
it's really
system. I think it's a neat idea. Cause once you push it in there and then you kind of turn around and
Yeah,
click
it
it,
has like a little lock.
little locking system, and it doesn't go. You can pull out the entire peg tube if you wanted to, because it locks into place.
Yeah.
Don't wanna do that, obviously, no problem, but, it's a pretty cool system, and then you can hook up your peg tube or your, syringe or your continuous tube feeding, something like that, and you just let it roll, so. He gets nutrition all the time, going on the highway, or, people look at him weird when he's sitting in Wendy's and you're just over here holding the 2 feeding bag after you eat your burger. And then you just stare right back at him, you know, so.
Yeah. Just liquid frosty.
What?
Liquid frosty.
Liquid frosty, yeah, so, we've never tried that before. But yeah, you put I guess you put beer or anything else down too. Anyway, cause he always goes NASCAR races. Alex loves NASCAR, that's his thing. He's probably got a NASCAR shirt on right now, he does, so, he just got back from Atlanta, not too long ago, from the NASCAR race, so. They got a camper and they just go around to all the NASCAR races and, trying to get to the infield at Talladega. Hadn't made it that far yet, several times together, but, that's what Alex likes to do, so. Alright, and then, let's see, go back, there we go. Musculoskeletal wise, what can we do for these patients, okay? So, starting off diagnosis around that 5 to 6 year mark, by the age of 9, they're gonna require the assistance of some type of wheelchair, okay? It's gotta be electric, of course, you can't use that upper body strength to push that wheelchair around, so eventually it's gonna be, electric as well. And then they're usually permanently in a wheelchair by the age of 12. Those ages vary, okay? So it's not, specific, every kid's gonna be in a wheelchair by age 12, okay? So it kind of ranges, some are a little earlier, some are a little later, just kind of dependent as well, okay? And so that's kind of how we get around the musculoskeletal side as well. We also have to think about pain relief as well. Talking about musculoskeletal system. He's got pretty bad contractures here and there, so arms really don't bend a whole lot, okay? So that's about his max right there is that he can bend, because he sits in his wheelchair pretty much 100% of the time, or he's sitting in the bed, one or two, okay? So even this adjusted Duchenne muscular dystrophy in general, okay? Someone that is wheelchair bound, we have to think about these things, about pain management. Same on this side as well. Okay. And then shoulder movement wise, doesn't have a lot of movement within his shoulders, so that's not gonna be cool. And then same with his hands, okay? That's really about as far as he can grip, okay? So we have to think about these things, right? Same with his legs. Legs have some pretty, significant. So see how we have that pointed foot, have kind of that drop foot. Also has to deal with the Achilles tendon as well. That's really tightened up. He has that swollen calf. But as we kind of transition to more wheelchair, permanent wheelchair setting, we're not applying pressure as we walk on our feet. We slowly get that downward foot drop as well. Okay. So what are some things that we need to tell our patients if they're in the bed 100% of the time, wearing a wheelchair 100% of the time? Tell them we're due, I guess. Turn every 2 hours, good. What else, anybody? Keep them dry, clean, intact, good, good. So his wheelchair actually does some cool stuff.
Hit the reset button. Aaron, move it.
Okay, so his will actually recline like a recliner. I know, right? And it'll go as far back as he wants it, as well. So he's just moving a little bit, trying to get off his butt just enough, and it just changes the pressure points in him. So he'll go way on back, and it'll also do just the back, it'll do just the feet, so he can really customize it however he sees fit, however he wants it, the most comfortable for him. Okay. He's getting a new chair upgrade here for too long as well, where it'll actually raise him up so he can look me in the eye, which is really cool. Allows for a little bit of independence as well, and it's kind of almost that psychosocial status as well. Just getting them able to interact with people, so they're not just kind of sitting by the wayside. All right. So it's gonna be great for him when he just goes to the doctor's appointment and he can just lift himself up, so he can look directly at the receptionist and say, "Hey, I'm here for this." Or if he wants to, I don't know why you would order a hamburger, but something like that, you know. So he can see other people, and he's not always staring at someone's butt in Walmart, okay? Because he's butt level, all right? So we're trying to give him some dignity with that as well.
You might not mind that.
But then I guess whose butt he's looking at. Whatever. So. Now his face is gonna turn all red. And...
She bent over right in front of him, and then she turned around and gave him an envelope. But I mean, she had on no shorts. I mean, what was she gonna do?
Something wrong or embarrassing. You know?
The eye dry thing too, he just got.
Yes, so so he's also getting another adaptation as well. And so at this point, he's not really able to move his upper extremities at all. Doesn't have that fine motor skill for the pitcher grasp and kind of moving his fingers and stuff. So how does he drive his wheelchair? So obviously I drove it really badly. My mom and them couldn't just zoom whatever. But what if my mom or somebody else isn't there with him and if he wants to go somewhere? So he's getting this thing called iDrive. So So basically, it's just a big iPad. It kind of sits in front of him, kind of just like that. And wherever he looks is where the wheelchair is going to go. So he's got it. They're still working the kinks out on it right now. But if he looks to the left, he'll turn left. If he looks straight ahead and he opens his eyes up nice and wide, that's how he goes faster. If he closes his eyes, it kind of constricts his eyes a little bit, kind of squints. That's how he slows and stops. So he's also working the kinks out of it too, and he forgets when he needs to stop, and he just keeps looking. So it's definitely a learning curve for that, but something cool. So they have a lot of different options out there, is what I'm getting at. And so we need to teach our patients about all these options. Okay, get occupational therapy involved, get physical therapy involved, get dietary involved if you need to. Okay, PT and OT know a lot about these wheelchairs, and get social work involved. They can get you pointed in the right direction for all types of needs. Okay. And then I wrote cosmetic on there, so that can mean a lot of different things. For instance, the foot drop. Okay, if Alex was real concerned about how his feet look, he wanted to be a foot model, he could actually get the Achilles tendon in his foot. Okay, not going to allow him to walk at all, but it's more of just a cosmetic thing, allowing for his feet to sit flat. Okay. Then you could go in and check out some care with that as well. Maybe he's real self-conscious about his Mickey button, so we maybe need to get some psychiatric help, some mental health in there as well. Most of the time he's just in his underwear, so he don't really care what it looks like. So, he actually has pants on today, so it's great. It's a great day. So, and that's just me in town. That was when I got my white coat for my nurse practitioner stuff. But anybody have any questions for Alex, or we can answer anything? That's muscular dystrophy.
Speech.
Speech. So again, he's not able to use his tongue appropriately. We use our tongue a lot for our speech. Not able to really articulate words as well. Not able to move his lips, kind of draw to actually articulate words. So he will speak. He just doesn't like to. He's very shy. So, but in general, they can speak for pretty long time. And then it kind of starts progressively gets worse, starts to mumble, real soft spoken. If you're with him every single day, then they really should exactly understand. But the eye drive that I was talking about, the iPad, it actually has the speech capability as well. So he'll look at I'm in pain, and then it'll say I'm in pain. Or he'll look at I'm hungry, and it'll say I'm hungry. Kind of like who's the famous guy? Steve Hawkins.
Yeah.
Christopher Reeve.
Christopher Reeve.
Steve
Who's that?
Christopher Reeve.
Superman.
There we go. Oh, yeah, Superman, yeah. And then, I was thinking Steve Thomas, but, he's able to speak.
How old are we?
I'm a youngster, okay? I know who you're talking about now, yeah. So, this is progressive disorder. Life expectancy is around the 18 to 19 mark, okay? So they told us that Alex would have never graduated high school. He's 26 now. Advances in medicine, continuation of care, really great care of a mother. She's basically a nurse at this point. Has really allowed them to live a whole lot longer. And so that's kind of the struggles that we are facing now. Do they go to a pediatrician, or do they go to an adult doctor? This is a pediatric disorder, so the adult doctors don't really know how to treat these patients, but he really needs adult medicine as well, because he's 26. What's up?
Does the physical therapy, help with muscle movement, or is it just kind of there to?
Mostly for continue to help the range of motion, to allow him to not develop contractures as much. Really, the physical therapy is in the kind of beginning stages, to allow them to walk as long as possible. And then it doesn't really help with strength necessarily, just kind of help with dexterity and help not get those contractures. And then as they kind of develop, physical therapy and occupational therapy kind of goes on the wayside. And It's for just kind of pain, symptomatic management.
How old were you when you stopped walking? Like, when you were completely
I was,
maybe 7?
seven?
7?
What else was I gonna say? Oh, it's also, it doesn't affect, his mental status whatsoever. He's not dumb. I mean,
Oh, yeah, he's gonna get you back for everything.
So,
I swear, when he's squinting his eyes.
He,
You're gonna get back.
he wanted to be a mechanical engineer, and he was smart enough to do that, okay? So don't talk down, to these patients, or just assume, that their mental status is not there just because he's in a wheelchair, okay? So direct the questions at him. When you're taking your health history, your physical history, direct your questions, to really anybody, you know? I really like it when they talk directly to Alex, okay? He may or may not say anything because he's super shy, and then at that point, then they'll talk to whoever the caregiver is. But when you're talking to anybody in a wheelchair or just anybody in general, don't assume their mental status, okay? Yes?
Hi, Alex. Do you still continue your education? Do you still learn things?
Basically.
Okay, that's good.
He really just goes nuts about this and just wants to play video games. He's living his best life, honestly.
NASCAR's great. I mean, that's an education itself.
No taxes, no jobs. He's not in nursing school.
Just an older brother that takes on.
Taking my money, you know.
He likes video games.
He loves video games, he plays a lot of Call of Duty, a lot of Grand Theft Auto.
Oh, it's great. Oh, Grand Theft Auto, yeah.
He loves Minecraft, he loves all these things.
You
And
play
they have a
Grand
lot of
Theft Auto and
specialty
you want.
controllers as
you
well.
know,
You gotta get a PS5, he's high class. He takes my money and buys PlayStation. Okay. Yes.
I have a question about, what do you think is the hardest part about having Duchenne? What's hardest?
You don't know exactly. Think of something.
Having a brother.
Yeah.
Follow up, when does he get to do a lecture about you? Yeah.
Next week.
Next week?
Oh,
What'd you
I'll
say?
be here for that.
Not being able to do stuff for yourself. I mean, he's pretty much my whole inspiration. I don't know if I told you that already, but that's, he's the main reason I got into health